Well, I'm excited to be back, to see familiar faces, and this is in fact a familiar classroom where I taught torts. So I've spent many hours standing in this spot talking about tort law, which isn't what we'll be talking about today. This topic is arguably much more exciting than tort law. So today I'm going to be talking about the evidence-based regulation of long-term care. So how do we design better regulations that actually reflect the evidence that's out there? All too often, regulation comes in response to headlines such as these. And these are all from the last 6 months or so, but you open your newspaper or turn on the news and you see reports of abuse in nursing homes, avoidable injuries. Quebec is now allowing patients to use video surveillance equipment in their rooms to catch abuse. You can see this CBC News heading, "It's a horror movie." And so all too often regulation comes in response to headlines like this. The government is pressured as a result of these things to act, and to act strongly and to act quickly. And what I want to do is take a step back and say, okay, well, if we were to design regulations based on the evidence as opposed to in reaction to situations like this, what might those regulations look like? What existing regulations is there good evidence for, and which regulations is there maybe less evidence for? And the reason for this is because while regulation has a number of benefits, it also comes with a cost. So some of the benefits are obvious. Regulations are usually put forth as creating greater protection for residents. I've put a question mark there because that's not always the case, as we'll talk about. A lot of regulations are designed to increase transparency and accountability. So a lot of regulations require reporting, which leads to greater transparency. Sometimes regulations are viewed as enhancing public trust. So the government is seen to be doing something. Long-term care homes are seen to be being held on the hook for something, and the idea is that the public is more trusting because of it. Regulations are also make the government seem responsive and reactive to problems with quality and safety. And then one of the other benefits of regulations that is sometimes discussed in this particular sector especially is their universal applicability. So the idea is that while some long-term care homes are good and are doing a lot in terms of quality and safety, others aren't. But if we make those activities mandatory, then there's that universal level of regulation that all long-term care homes subscribe to. So there are these benefits, but regulation also comes often at significant cost. Sometimes these costs come in the form of a cost to resident autonomy, well-being, and mobility. So if we're very, very concerned about falls and we pass a whole bunch of regulations that restrict the ability of residents to move around in order to avoid falls, that's coming at a cost in terms of autonomy, mobility, and other things. So there's often a trade-off with regulations, and we'll get into a data example later of that trade-off. Regulations also have significant financial costs. It's interesting. I went to a meeting the other day with people from Alberta and BC long-term care homes, and there were a couple of people who own homes in both provinces, and they say that the cost of reporting requirements in BC, which we'll talk about, are astronomical, that they spend thousands of dollars reporting things to government on this long list of things that has to be reported. So are we getting any value from that money that's being spent? Ontario is another province that is very extensively regulated in the long-term care sector. If you look at their legislation, it's triple, quadruple the length of some other provinces. So there's a lot of regulation in Ontario. And if you talk to long-term care home administrators, they'll say that they spend a lot of money complying with regulations. Another concern with regulation is that it might create a regulatory floor rather than a ceiling. So people who are already doing more, if all of a sudden they're subject to a whole bunch of regulations, might just bring themselves down to that mandatory level, and instead of doing whatever they're currently doing that exceeds what the regulations are asking them to do. Regulations might also shift priorities. So instead of doing things that, providing healthcare services for residents or providing leisure activities for residents, financial resources and human resources can be diverted to regulatory compliance. And then a final issue that comes up with regulation is that it comes at government expense too. Government has to have the enforcement capacity to deal with all of these regulations. And this has been a problem in several provinces. When Ontario passed its most recent round of long-term care legislation, they had to hire a bunch more inspectors. And even now, just recently, they've announced that because of the level of detail that's required, they're actually dialing back their annual inspections. So every 3 years, they'll do a very thorough inspection, and in the off years, they'll do a light inspection because they just don't have the manpower to enforce these regulations. Ontario has a lot of reporting requirements as well, and so the inspectors are spending a lot of time on those. So given the costs of regulations, which ones are actually shown to have some benefit, which appear not to be working? And so this really, my research really kind of boils down to these 4 questions. So there's significant interprovincial variation in the way that long-term care is regulated. There's also significant interprovincial variation in the quality indicators. And so can we map these differences in legislation onto these differences in quality indicators and say, to what extent are these differences in quality indicators actually attributable to regulatory differences? So if there's some province that's regulating something in a different way than other provinces, is that showing up positively or negatively in the quality indicators such that other provinces can learn from that and design more evidence-based regulations? So really taking advantage of both the interprovincial variation, but also in the really good data that we have in this space. So some of you are probably familiar with the continuing care reporting system. Some of you are not. But CIHI's website has a lot of information on this if you're interested. But basically, we currently collect some provinces almost universally across long-term care facilities. Other provinces have more spotty coverage. But we currently collect very extensive information on demographics, administrative data, and clinical data on long-term care residents. The data set has expanded over time, but at this point it covers 100 and some odd thousand residents. So it's across Canada. And it has more than 500 data elements. So we have data on, these are really just examples because there's 500 indicators, but there's a number of indicators relate to cognitive function, psychological well-being, the residents' health conditions, their skin condition, the medical treatments they're receiving, their behavior, like aggression, that sort of thing, their functionality, if they have any disease diagnoses, what their nutrition is like, their activity patterns, and the list goes on and on and on. So we really know a lot at the resident level, and therefore at the facility level, and therefore at the provincial level about what's going on in long-term care homes. Nursing staff collect this information and input it into the database. These assessments occur generally quarterly unless there's a triggering event. So if you go to hospital and come back, then that might trigger an assessment. But even without any event happening, they're done quarterly. So we're getting this data often, and we're getting lots of it. So we know a lot about sort of the quality of care, but to what extent do regulations map onto that? The other thing too, although I'm not looking at this yet, for those of you who are interested in this data, this data is also collected internationally. So if you wanted to look at Canada's regulation of long-term care versus other countries, there is, and not by all countries, but many countries use the same database. Okay, so I've talked about this regional variation, and I wanted to show you what it looks like. So, and I've picked a few data indicators, the ones that CIHI has chosen to focus on themselves in their reports. So this is the percentage of patients who report that they are experiencing ongoing pain in long-term care. So their pain isn't being effectively managed through medication. They are feeling pain. As you can see, there's a lot of variation between provinces. Alberta and Ontario seem to be more effective in this space, whereas the Yukon, which has excellent data compared to the other territories, the Yukon and Nova Scotia, or so Newfoundland, less effective at managing pain. It's been speculated that that's partly perhaps related to staffing levels in those jurisdictions, but we don't know what the causes of it are. Similarly, and this is another data indicator that gets a lot of press, and that is the percentage of long-term care residents who are taking potentially inappropriate antipsychotics. And what makes them potentially inappropriate is that they're taking them with no underlying diagnosis of psychoses. And so probably some percentage of those people could be diagnosed, but the rest of them, the concern is that people are being given antipsychotics to manage aggressive behaviors, to keep them compliant, these sorts of things. So as you can see, the figures in some places are shocking. It's pretty surprising that it's 38% of residents in Newfoundland versus about 17-20 in Alberta, Ontario. So that's pretty significant variation. And I think again, some people have speculated that in some of those jurisdictions it may be partly a staffing issue. Less staff, it's easier to ensure compliance through medication. Another factor that CIHI has focused on and has done reports on is the percentage of long-term care residents who report worsening depression between those quarterly assessments. So how many people report that their depression is getting worse? And they look at sort of depression in 3 different ways: no symptoms of depression, some symptoms of depression but no diagnosis, and then an actual diagnosis of depression. And this encompasses the latter 2 categories. So you can see, even though people in Newfoundland are not depressed because they're all taking antipsychotics, we don't really know how these factors play into one another, or maybe they're just more sort of stoic in Newfoundland and they don't report feelings of depression. But again, interesting interprovincial variation there. And I have one more slide to illustrate the variation, and that is the percentage of long-term care residents who are restrained in some way daily. And it's high in some places, right? 19% of people in long-term care homes in the Yukon Territory are restrained daily, and that includes chemical restraints, physical restraints, etc. Whereas Ontario has managed to get itself down to about 5%. But incredible variation there. So to what extent does any of this tie into the legislation? With restraint use, it actually seems to, in some ways, tie into the legislation. The Yukon and Newfoundland, they have very high use of restraints, 19 and 14%. Whereas, and they say their legislation is totally silent on the issue of restraints. Use them, don't use them, the government has nothing to say about it. Saskatchewan has 10% use, and they have a little bit of regulation. So generally the legislation says that you can use restraints, but only for health-related purposes or in emergencies, but very broadly worded. Saskatchewan also says if you're going to use restraints, you have to use the least restrictive restraint available. BC has a little bit more regulation. They much more narrowly word the situations in which restraints can be used. They also say that restraints have to be least restrictive. BC has an obligation to continually reassess the need for restraints. Employees have to be trained in restraint use in BC. And then there's pretty extensive documentation requirements if you're going to use restraints, documenting how they're used, when they're used. And so BC has less restraint use. If we look, Ontario has the lowest restraint use, and they also have the strictest law in this area. So facilities have to have written policies to explain how they plan to limit the use of restraints. They have to use the least restrictive restraints, and certain restraints are actually prohibited. So if you go into the regulations, it talks about very specific restraints, chair restraints and jacket restraints, and it prohibits the use of certain types. Similar to BC, there's an obligation to reassess should this person still be restrained, but Ontario goes further and says it actually has to be a doctor or nurse doing that assessment. Employees have to be trained in Ontario just as they do in BC, but Ontario adds the fact that we're not just training them in how to use restraints, we're also training them in how to minimize the use of restraints. Documentation requirements, of course. Ontario also has monitoring requirements that don't exist in other provinces. So people who are being restrained have to be checked on every single hour. They also have to be repositioned at least every 2 hours. And then in Ontario, there's actually a legal cause of action. The legislation creates a legal cause of action for inappropriate restraint use. So in this case, I don't think we can obviously attribute all of this variation in restraint use to the legislation, but at the very least, the legislation doesn't seem to be making things worse. Perhaps to some extent, the legislation is positively contributing to Ontario's lower restraint use. Not in and of itself, right? This isn't a single cause, single effect situation, but it's perhaps playing into lower restraint use. However, the legislation doesn't always seem to be correlated to differences in quality indicators. So as you can see here, again, we have not a ton of interprovincial variation, but this is the percentage of long-term care residents who, between assessments, had a pressure ulcer or a bed sore that became worse. You can see that Ontario is pretty much on par with many other provinces. So what does the regulation here look like? Ontario is the only one to regulate in this space. And they have in their legislation, I've tried to sum it up here, it's actually much longer. So facilities have to develop and implement skin and wound care programs. So that's all documented. They have to ensure that nurses assess residents who are at risk within 24 hours after their admission and after absences. Most people, or the most common period during which people develop pressure ulcers is when they first show up or when they've come back from hospital, because you've come back from hospital, you were probably in hospital because you had something that affected your mobility. You come back and your mobility is still compromised. Nurses have to assess and immediately treat residents with any skin integrity issues. And then residents have to be repositioned every 2 hours or more if their condition dictates it. So if you can't move around yourself, under the law, somebody comes in and moves you every 2 hours. So Ontario has all of this regulation in place, right? This is getting reported on, this is getting inspected. People are putting time and effort into this particular regulation. And it doesn't suggest that's playing out in the data. It doesn't seem that I guess we could say that they might be much worse if there was no regulation, but it seems that other provinces are doing just as good of a job on this particular indicator without having to put it in legislation and then have the associated kind of compliance costs and reporting requirements. So, and there are other indicators that I could have showed you. In some cases, the regulation seems to map on to the quality of care being better or worse. In other cases, though, it's the same. And so what policymakers maybe can take from this is that, maybe we should be looking at what some of these provinces with stricter laws are doing in spaces like the use of restraints, whereas somewhere like this, maybe other provinces wouldn't want to emulate Ontario's regulations because they're doing just as well without them. One of the things, though, that complicates all of this is that you can't look at these variables in isolation. They play off against one another. So you can see this graph is from Ontario data. So you can see that over the last several years, Ontario's use of potentially inappropriate antipsychotics has plummeted from around 32% to around 20%. That's a pretty significant reduction. Similarly, the use of restraints has fallen in Ontario from about 10% to about 5%. So that's also pretty significant. But you can see there's a trade-off. Falls have gone up. So we're medicating people less and we're restraining them less, but more people are falling. So falls have gone from 14 to about 16%. And that's again between those periods of assessment. So, if we just looked at falls, if all we cared about was falls, we might be very concerned that Ontario, oh my gosh, more people are falling. But, it can be connected to some of these other factors where they're doing things that are exposing people to more falls, but the trade-off might make sense, right? And if we can dig deeper in the data and look at things like mobility, activity levels, and those are probably up as well, and those are all the sorts of things that can lead to falls. But I think policymakers would probably agree that in some cases there are appropriate trade-offs where one of these variables or quality indicators will get worse, but if we look at the ones that relate to it, it might be a trade-off that they want to make. So there are, of course, limits in this data. The data itself is limited, right? Nurses input it. Is everybody inputting it in the same way, consistently, perfectly? Probably not. There are also confounding variables. Like we can't say that the legislation is completely responsible for Ontario's lower restraint use, for example. There are also non-legal factors, right? Maybe the Ontario Quality Council at the same time was really pushing for lower restraint use. Maybe it had almost nothing to do with the legislation. Maybe there was a case of a news expose in Ontario on restraint use, and so the lower rates were a response to that. The legislation can't take total credit for changes. I've already mentioned this second issue, but some variables don't correspond to a single law reform. Sometimes you have to look at a number of different variables or a number of different law reforms to get a sense of what's going on in a particular area. So for example, rates of depression, what law reform can we possibly connect that to? And the answer is a number. Some provinces have legislation requiring activities and requiring long-term care facilities to have activities coordinators. Maybe that's correlated to lower rates of depression. So there are some variables that don't map on to law as easily as things like restraint use or pressure ulcers. The other thing that I find challenging is that it's difficult to determine, like if you're looking in at Ontario and they passed a new law and restraint use went down, what dates do you use? Do you use when the bill was introduced? Because if the bill is introduced, you assume that long-term care facilities are already responding, knowing that it's going to become law. Do you use when the law is passed as your kind of date of comparison, because that's when facilities absolutely have to be doing whatever the legal change says they do, or when it's in effect? So, it's when you're trying to compare, did this law have an effect? Sometimes it's difficult to know what date to use, right? And that can I think muddy the data a little bit, and that's not just a problem in this space. That's a problem with any empirical study. Okay, so what are we going to do with all of this information about data? So the government can, of course, look at what other provinces are doing and change their laws. The other thing, though, they can do is to use their own regulation smartly. So if you're a province and you're collecting data or you're regulating a particular area, how can you best make use of that data you're collecting or those regulatory requirements? And so this is what I would call the evidence-based use of regulations you already have. So we, of course, want long-term care homes to change their laws to be more evidence-based. But if you're not going to do that, at least use the ones you have in an evidence-based manner. And so this is an example from BC. I mentioned before that BC has some of the most stringent reporting requirements, so stringent that they're microscopic on this slide. So BC, in their legislation, creates this definition of reportable incidents, and the government gets notified of all of these things. Some of them, I think we can get behind, right? Attempted suicides, death, disease outbreaks, abuse. We can see why those things are being reported. That all makes sense. Then we get into things like emergency use of restraint. I mean, what if it was very temporarily? What if the substitute decision makers were called, they were fine with it, the end? That's going to the government. A missing person. What if they were missing very, very briefly, they were found, there was no risk to them? That's all getting reported. Unusual behavior, that's very vague. That's getting reported. Unexpected illnesses, that's all getting reported. The government is getting all of that data. I mean, what illnesses are truly unexpected at that age? Almost any illness could be expected. The other one that's interesting is falls. So falls that require medical care are all getting reported to the government. So the BC government is getting copious amounts of information from these long-term care facilities, and what are they doing with it? In the case of falls, it would seem that they're getting all of this data on falls, but their fall rates are actually among the worst in the country. So this is the percentage of residents who fell between assessments. So Nova Scotia, maybe because they're restraining everyone, has really low rates of falls. They're 9%. BC's rates are 15 point, I think that's 7, I didn't put the decimal in, but 15.7 or 8% of residents in BC. Among the provinces for which there's decent data, only Manitoba is worse. So BC, you're the only province that's making all of these facilities report falls to you. And so you have all of this information on who's falling, when they're falling, how they're falling, but they're not, they don't seem to be taking action with that information. And maybe it's because they're requiring too many things to get reported. And so they're just getting too much data and they're not able to act on it, perhaps. Another example of this evidence-based use of regulation is inspections. So the frequency of inspections varies quite significantly across the country. Some provinces just sort of say in the legislation, we may inspect. Oftentimes those provinces have sort of policies of doing annual inspections, but the legislation just sort of leaves it at may inspect. Nova Scotia is doing twice a year inspections of every facility. Ontario is doing once a year inspections of every facility. Ontario also has a whole list of events that will trigger an inspection. And then the bottom row is just what happens after there's an inspection. And different provinces have different rules there, but generally the inspectors can order a correction plan, can cancel or suspend a contract, can prohibit admissions or restrict admissions to the facility, these sorts of things. And so one of the things that I think is interesting here, where the data can play into inspections, is given that we have facility level data, instead of going to every single facility in Nova Scotia, for example, and inspecting every single thing there twice a year, because we have facility level data on all of these quality indicators, yeah, maybe you keep your annual inspections, or maybe you even dial those back, but you can actually target inspections to specific facilities on specific quality indicators. And so this is some Ontario level facility data. I didn't fill in the whole chart because then it's just sort of mind-numbing amount of data. But as you can see, falls vary in Ontario. Some facilities are at around 3.5%. Other facilities, though, 11% of people fell between those two assessment periods. And so, are the people at Norfolk and North Lambton sicker? Maybe, but they have that data as well. And so, if we have this variation, instead of just inspecting everybody all the time, that discretionary power to may inspect at any time, they can use it to target specific facilities on specific quality indicators. So in other words, they can take the regulation they have and use it in a smarter way. And so we see the same variation across other indicators. So pressure ulcers are under 0.5% at several facilities, and they're over 1.5% at others. Antipsychotic use is 2 or 3% at some facilities, and it's 15% at others. And so maybe instead of just doing these annual inspections, they can target the ones where maybe there's a problem. And maybe there's not, right? Maybe the clinical population supports it, but the government has that data as well. So to sum it up, so that we leave time for questions, the crux of it is that regulatory compliance and enforcement by the government is costly. It's costly financially, it's costly in terms of human resources, it's costly in terms of they may be doing other things that are more important, people who work at long-term care homes. It can also be costly in terms of residents, right? And their well-being. If we care the most about you not falling and we keep you bedridden, there's trade-offs there. And so I think that governments need to take advantage of this considerable interprovincial variation in regulation, and also this considerable interprovincial variation in knowledge of quality indicators, and shift towards regulations that are more evidence-based. And then similarly, and then for variables like restraint use, where maybe legislation does play a role, great. Some provinces can look at what Ontario is doing and consider implementing it. For other variables like pressure ulcers, where Ontario's stricter regulatory scheme doesn't seem to be linked to lower rates of pressure ulcers, then we can use non-regulatory strategies, right? We can turn to health quality councils to develop guidelines in those areas, these other sorts of strategies. We can do research in these areas, whatever it might be. Where regulation isn't effective, there's no point in having it. And so what other kinds of strategies can we have that are non-regulatory? And just as ideally, we would want evidence-based regulations, even if we can't have those, at the very least, governments should be making use of the data that they do have about their current regulatory strategies and the facilities within their jurisdiction to make evidence-based decisions around things like what to do with information that's reported and inspections. So I will leave it at that and turn it over to you for questions.
Thank you very much, Lorian. This is really fascinating, and we're lucky that someone is spending the time to
Before we're all old and in a long-term care facility, ideally.
It's an important exercise, and it's very revealing and extremely interesting.
Yes.
Well, let me get the ball rolling. I really appreciated the talk. It seems to me one of the next steps would be to phone up somebody in BC or in Kaihai and say, are you analyzing these data? Have you done that?
No, I've talked to a few people in Alberta. I've talked to some long-term care home operators who are very interested in this. But I don't think the government is. I actually talked to someone in Alberta who's working on law reform, and they weren't using the Kaihai data or the MDS data. So they have no intention of having evidence-based regulation. That's just not their thing in Alberta. They wouldn't say it like that, I'm sure. But so I met someone who's working on they're thinking about opening up their long-term care home legislation, and I asked them about this, and
Well, you're pointing to something that cries out for some analysis, and one of my themes in general is that analysis is way underinvested by governments across the country. So it's part of the lack of evidence basis for so many things. I also think, you've lauded the Kaihai data. In another project I'm doing with this lady right here, we're finding that it's rather more limited from when you start drilling down into it. And part of the reason is people aren't using it. People used it and started asking tough questions. I think you'll find that the frequency of these assessments isn't as high as you want. It's really quite spotty. Nova Scotia hasn't, I was just on the phone with Nova Scotia, they haven't submitted anything since 2012 because they changed their data system and it's taken all this time to figure out how to connect it back to the Kaihai.
Yeah, and that's why I only put some of the provinces on that map. Some of them, the data is so bad that Kaihai themselves will tell you this isn't reliable data. They'll say that these are the provinces that we have enough data to actually report on and that you should use in your research. Because there are some provinces where not all long-term care facilities report. It's only sort of the publicly funded ones, or it's only, so yeah, absolutely. The data, there are weaknesses in the data itself.
Go ahead, please.
Yeah, thank you. Thank you. This has been really great. Just regarding the second point, that the regulations should be evidence-based and, we should get rid of the ones that are ineffective. But in some ways, don't we only have that evidence because there are the regulations in some provinces that may be at the forefront of these issues, and we're learning perhaps on those particular issues the regulations maybe were ineffective, or the other smaller provinces are looking up to those larger ones who are providing leadership?
Yeah, and you always run in, sometimes you only get good data because somebody's doing something poorly, and I would hope that both provinces themselves, every decade or however often they open up their legislation to significantly amend it, and several provinces right now are looking at amending their legislation, and so the hope is that provinces are able to be self-reflective when they open up their legislation. What are we doing that maybe isn't supported by the evidence? And so even if they did sort of act as a pioneer in an area and try and do something and didn't seem to pay off, then you would hope they could be somewhat self-reflective and say, well, maybe this is part of the legislation that needs to be changed. But I think you're absolutely right that other provinces, and there are several who have decades-old legislation, you would hope that when they get around to fixing it up, that it's to their benefit that they have several other provinces who have tried different things, right? So we talked about the fact that several provinces say nothing at all on restraint use. Well, so if one of those provinces is opening up their long-term care home legislation, and that's an issue they want to look at, they have several provinces who have regulated in that area to draw from. And so the hope is that they're able to both learn from their own experience if they were a pioneer in an area and it didn't quite work out, or the regulations weren't effective, but also that the smaller provinces that haven't opened up their legislation in years, that then they can hopefully draw from this kind of research and thinking so that their regulation can be state of the art.
I'm wondering if there's significant variation province by province in the training that personal support workers receive, and if that's having a significant influence on variables such as use of restraints or the so I guess the proclivity to use antipsychotic medications, a bit more liberally, for lack of a better word. Have you encountered that in your research?
Yeah, certainly at least anecdotally, and some of these provinces have not necessarily in their legislation, but some of them have long-term care home standards that talk about staffing levels and talk about having to have a registered nurse, at all times in the facility, or there are sort of rules around staffing levels, but they tend to focus more on doctors and nurses and sort of when they have to be present or available, and less on the training of other healthcare workers like personal support workers, because the training they get varies incredibly, right, as compared to say nurses. There's an incredible amount of variation in that training, and and maybe that's something that governments. I talked about kind of non-regulatory strategies, maybe looking at personal support worker training. Is something that is one of those non-regulatory strategies that might pay off.
Isn't that potentially regulatory as well?
It could be.
The whole scope of practice kinds of legislation.
Yeah, they could open that up, but a lot of the scope of practice legislation are sort of these restricted clinical acts, like you can't do surgery, you can't deliver a baby, you can't set a fracture. A lot of the stuff that personal support workers are doing is really like feeding people and moving people, and so it doesn't tend to be sort of captured in the same way by that legislation. But there's no reason that they couldn't devise a way of regulating it, just as they regulate other health professionals. I think facilities too, though, also need to, that's something they need to be aware of, because a lot of the training for those workers actually comes from the facility itself.
I'll have Colleen and then Ms. Lady comment on it.
Thanks, Lorian. It was really so interesting and so great to see trying to fuse, the data that's out there with developing best practices and regulation. just have a simple question. I have a lot of questions actually, but I'll just ask this one now. That's about, have you made any attempt to try to correct for morbidity and the specific nature of the populations that might be in the different provinces? Because I would imagine, for example, that Nova Scotia and Newfoundland may actually, because they have a much older population, that the frailty of the population inside nursing homes might be higher, much higher perhaps than in Alberta. I don't know that to be true or not, but I'm imagining that it could be possible. So does CIHI give you the, are you confident enough that you're comparing apples and apples when you're looking at that?
No, that data does exist. I'm not confident enough that the data on sort of restraint use reflects it, and so someplace like Newfoundland might be an outlier with Alberta has a young population, and interestingly, despite their young population, they don't perform fantastically on all of the indicators.
Yeah.
I think the facility level data is really problematic because it's not adjusted by morbidity, and different facilities cater to very different populations. I think when you get to the kind of province-wide level, some of that is massaged out. But I think absolutely, another level of refinement to the data would be to compare who's in nursing homes in these different provinces. I mean, to some extent, even though Alberta has a younger population, I think Saskatchewan might as well, even though they have a younger population, are the people that are in long-term care homes all that older and sicker, or is there's a threshold level of oldness and sickness to get in long-term care home? I mean, it's hard to...
Is there an answer to that?
Oh, sure. CIHI, I don't think they're finished, but they're in the process of developing something called a case mix adjuster or some similar name. But what your question cries out for is multivariate analysis. And
I feel ill already.
Some statistical analysis where you put on the right-hand side of the equation not only age and sex, but also, how is the person sick with arthritis? Is the person got dementia? What kind of drugs are they taking? And you can put as the thing you're trying to explain is the rate of falls. And then you put another variable, is this province I or province J? Is it facility P or Q?
Mm-hmm.
That's the way to do it.
Yeah.
My conjecture is that there's nobody in the country who's doing it. And part of the reason is it's a bit of a pain to get the data. CIHR isn't funding anyone to do it, and on and on. The provinces, BC, it sounds like they collect marvelous data. They do have people there who are good at doing this kind of analysis. They're probably all in cancer care rather than long-term care because that's where all of the money, but partly because that's where the public is most worried.
Yeah, and you're right, there's not a lot, and maybe there's some internal government analyses going on, but there is not a lot of publicly available literature analyzing almost any of this data set. Like if you put the continuing care data sets in Canada into PubMed, there's not a lot there, and so unfortunately there aren't people doing that kind of analysis. Unless they're in government and not publishing their work.
Thank you, that was great. Just to go back on staffing levels, of course, the training of orderlies or personal care workers, and even the term changes from province to province. The training indeed varies incredibly, and it doesn't seem to be regulated, and that, I think, some years ago, Nova Scotia, in Halifax, they were doing a really good job of the college working with care homes to develop programs, to actually train orderlies that could deal with individuals with dementia. You can imagine it, one issue is the population now entering long-term care has their teeth. They don't have dentures. Trying to brush someone's teeth when they have dementia is a challenging task. So things like that, little micro things that they were paying attention to. So that's really, sort of encouraging to see that initiative. But again, it's outside regulation.
Yeah, and I've heard of even just anecdotally, I've heard of very different levels of training. I mean, I've talked to people who operate, 10 or 12 long-term care facilities, and they often have pretty significant training programs because, of course, they're training. If you have 12 facilities, you're training tons of workers, and so you develop probably more effective training programs just because you're training people all the time. Whereas, maybe some of the smaller facilities just don't have the resources to develop those kinds of training programs. And so, one might look to the provincial health quality councils to develop guidelines in that regard.
I don't know if Quebec has changed, but a while back, they were also, there were ads, on the radio. You can get, your license in 6 weeks. So they were really targeting minority populations who, needed a job and so on. So again, in 6 weeks, you can't imagine it's great training.
No, and there are really interesting issues too with the conditions of work that those workers face and sort of resident aggression. We measure resident aggression, but we tend to focus from the perspective of the resident, right? Were they aggressive to someone and another resident was injured? But there's really interesting issues there. We know a lot about doctors, we know a lot about nurses. There's lots written, there's lots studied, but we certainly know less about support workers.
Yeah, and the other thing too, I don't know if staffing levels are, I know in Quebec, again, it's where I sort of have some experience, that the unions had better requirements for staffing of orderlies than the government. So that made for better care, actually, incidentally.
Yeah, I had, I met someone from a long-term care facility the other day, and they operate a few long-term care homes, and one of theirs is unionized and the others aren't. Mm-hmm. And I, too, was, what does this tell us about the data? But they weren't very receptive to my query, and they sort of said, no, all of our facilities have the same standard of care. I haven't yet gone to the facility level data for them because it was just the other day, but I'd be curious.
Mm.
But there's a trade-off, right? Because more staffing can mean more healthcare professionals, but if you're only able to charge residents so much, in Alberta, for example, they cap the daily charge that residents can be charged, and so the money has to come from somewhere. And so if there's sort of caps on the money they can make, and they're spending lots on healthcare workers, are there still the same level of recreational programs and these sorts of things? And what's better, right? Another X number of minutes a day with a healthcare worker, or the recreational programs and those sorts of things that might impact rates of depression. So yeah, there's always these tough trade-offs that. What's about to happen?
That was really interesting, thank you. I work for the LIN, and I can tell you that we don't have a lot of data on long-term care homes, which is really unfortunate. It's mostly with the ministry, like at the provincial level. My thought when I was looking through your deck when you were presenting was, when you're saying to adjust the legislation based on the data, my question for you would be, how valid is the data? And you touched on that a little bit earlier. You said, CIHI will omit provinces based on, kind of spotty data and things like that. But even in terms of the data that we are using, how are we validating that 100% of the falls are being reported? And to base legislation, which is very impactful for these patients and the workers and the administration staff, if we don't have a good measure of what percent of falls are being reported, period, I would kind of be hesitant to base the legislation on that data, because like my spouse works for a long-term care home.
Yeah.
And he's even said when the inspectors show up, it's like a whole different bag of tea, they change, they almost go to changing their procedures. Like they'll throw their soiled linen here instead of here because there's a ministry person on the floor, right? So it's very kind of biased in that way, and it would be interesting to see, or I don't know, I'm sure they know this, right? It would be interesting to see what measures they take to account for the validity or the potential margin of error or things like that in the data that they're presenting.
Yeah, all of this data is all built, interestingly, around sort of this individual nurse interacting with individual resident and inputting the data. And that relies a lot on this individual person to do their job, which that doesn't always, we've all had jobs that we've done what we're supposed to do. And so,
Really?
yeah, yes, I used to work here for you, surprise. But no, I think that there's always going to be limits in the data, and we're never going to have perfect data on something like falls. The falls, like in BC, where if somebody gets hospitalized, that has to be reported to the government. Maybe there's good data on that because they think that could get back to them. But just your regular Joe fall out of bed that doesn't require hospitalization or visit to the hospital, those are going to be underreported, of course. I guess two things. When we're looking at it on sort of a province-wide level, could we maybe assume that the underreporting is somewhat uniform across provinces, such that, if BC says 10% of people are falling, Ontario says 8%, those are probably 10 and 12 respectively, but maybe there's some inconsistency in the level of reporting when we aggregate at the provincial level. At the institutional level, I don't think you would do that, because some institutions would have a better reporting culture than others, but maybe when we get to the provincial level, I guess the other thing too is, the data is never going to be perfect, but most of the existing legislation is based on no evidence whatsoever. It's based on just what people think sounds like a good idea. And it's based on, oh my God, this thing happened, the government needs to do something, or it's decades and decades old in some provinces, and it's just, like, what do we think is a good idea? And a lot of it was based, some of it came from hospitals legislation, which is several decades even older. And so I guess, yeah, the legislation is never going to be perfectly evidence-based, but most of it is not evidence-based at all. So I guess, my suggestion is just sort of that they have to do the best they can with the best evidence they have. And, maybe part of that is changing regulation, but maybe part of that is pushing for better data as well, and governments themselves, and, doing things to validate the data. But yeah, you're absolutely right about the underreporting issues.
It's definitely going in the right direction.
Yeah.
Like, it's fundamentally, I think that's what they need to be doing. So
Yeah.
it's great.
Yeah, you mentioned you work for the LIN. There's the CAI reports on some of these indicators on inter-LIN variation as well. Erie is the big culprit among LINs. I'm not. You wouldn't be in that LIN, so I feel comfortable saying it. I was looking at the LIN level data a couple days ago, and they seem to pop up as not performing so well on some of these quality indicators. So, so you can actually look at facility level, LIN level, province level, and then nationally.
Back to me. So I just get really too excited about this sort of stuff. So yeah, but I think your question is so interesting, and maybe something to think about when you're writing this up is that the sanction that might come down to bear on a nursing home in Ontario that doesn't comply with or makes a mistake around the restraint issue, both on the individual and on the facility, I think needs to be taken into account a little bit more than what you're saying, because they may be underreporting more because of the possible sanction. And you mentioned, the possibility of a legal, a freestanding kind of legal right not to be restrained. It's actually written into the legislation, so there's obviously also the possibility, if not the reality, of a tort claim. So there is, that needs to, that might make me, if I'm a provider, hide, right, something, or try to hide it, or as a facility level to actually have a policy to make sure that unless, you're going to be caught red-handed, that you kind of keep that under wraps. There's a possibility,
Yeah.
right? So
No, I don't think.
I think that might need to, so I think the issue of enforcement needs a little bit more, you probably haven't had time here, but just to really kind of work that out, because as our colleague here from the LIN said, is this the trumpeting, we'll be here in 1 month, get the beds ready, or is it, they just show up, right? And if it's well, no, we're telling you we can't actually make it every year, we're only going to come every 3 years. I mean, to me, I'm why would you do that, right? Why would you keep that kind of your powder dry in your back pocket, that you may just show up as a sort of method of enforcement. So when I think about smart regulation, I think about that kind of thing. How can I get as much bang for my buck with my, my regulation, from the enforcement level as well. So that doesn't mean, having armies full of inspectors necessarily, but using things like spot checks, right? Also, I think about technology as a possibility here as well, the pros and cons for technology. But I think a lot of those media stories you came out were, as a result of patients and their families, particularly their families, using kind of cameras and things to show some of the appalling stuff happening on the inside. So I wonder about that. What you think about some of the enforcement questions.
And the enforcement stuff is interesting because, there's often a discrepancy between what's in the legislation and what's in practice, and so it's very nuanced thing to try and look at, because if you look, it's all of them kind of may inspect, but that looks very different in different provinces. And Ontario's legislation says annual inspections, but they've now said annual light every 3 years real inspection. And so I think and some provinces have more inspectors, and so they know things will be followed up on. And so I think you're right, all of that will certainly play into how fearful people are and how willing they are to report. Ontario also gets tons of reports because they have a lot of people as mandatory reporters of abuse, neglect, etc. So they have more mandatory reporters and more things that trigger those kinds of reports than other provinces, right? So there was a news heading the other day that said reports of abuse up 158% in Ontario, and there was a regulatory change, and they were looking at data pre-regulatory change, so it looks like the whole thing's a disaster, and people are calling for more inspectors. But in that case, it was they're getting more reports, but it was stuff that was being underreported. So yeah, and I think different facilities. I've talked to people about sort of how they view inspectors and how they feel about inspectors, and sometimes when it's kind of an annual inspection and they know it's coming, then you roll out the red carpets and everybody's clean and fresh and happy and like playing croquet on the lawn. But most provinces do have and I paint a lovely picture. Most provinces do have the legal authority at least to do spot inspections, and I think I would also advocate spot inspections, particular facilities where there's concerns, and particularly on particular quality metrics where there's concerns. Like, if one facility is having a bunch of falls, you don't just show up and do a full inspection. Show up and inspect things that are specific to that issue. See, now you want to go live in long-term care, so you can just play croquet on the lawn. I painted a beautiful picture.
Just on the spot, a couple things on the spot inspections. CRA already does some statistical analysis to decide which returns to audit, and I don't know if it's still going on, but at one point I think the Ontario College of Physicians contracted ICES to do a study on how they should target doctors for review. So it's well established in other areas. On the difference between the law and the enforcement of the law, I wonder if you could, if it's possible to get some idea of the number of inspectors or inspections in each province, or the budget for inspection, so that you'd have some basis for at least a rough indication of the amount of enforcement effort. And the others, the name has changed, so I don't remember, but there is a national organization that does quality assurance. You get certified at what you've done. It's starting to be a hospital-only thing, but they've branched out. They're just over here on Saint Laurent. Their offices.
Accreditation Canada.
Accreditation Canada. That's it. Yeah. Have you thought about talking to them and see what they've been doing?
I haven't talked to them, but I have certainly looked at their accreditation guidelines for long-term care facilities, and some provinces have a set of standards apart from legislation. They have a set of standards that are often kind of built into legislation. Alberta, for example, has 70, 80-page standards document, and the legislation incorporates it kind of by reference. You have to comply with these standards, and they largely mirror what Accreditation Canada is doing in long-term care space. So they've clearly borrowed from Alberta's clearly borrowed from those accreditation standards. So I've seen the standards. I know that some provinces are certainly aware of them and have, in some cases, built them into their legislation. But I haven't yet sort of spoke to someone at Accreditation Canada to get the word on the street, the dirt, the inside info. But I think that's absolutely a good suggestion.
Yeah, that was going to be my questions about accreditation.
Yeah.
Canada, 'cause the sphere that I work in, Accreditation Canada has played a really important role in terms of filling a regulatory vacuum. Right? There's a lot of provincial legislation for fertility clinics, and so Accreditation Canada has really stepped up in terms of coming up with standards, and the clinics have responded by really wanting to be accredited so that patients have confidence coming to their facilities that they have met certain standards. And I'm wondering if you've seen anything similar in the context of long-term care, because I know they do have standards around long-term care.
They do. I think the long-term care space is interesting because if the governments weren't willing to regulate, I think it could fill a gap. But here we have an interesting situation where the governments are very willing to regulate, often either too much or too little, right? And so in that case, there's not so much a vacuum as
This tension,
potentially
right?
tension.
Yeah.
And so, one would hope, I don't know the extent to which provinces are working with accreditation. I know some provinces use the standards or have borrowed from the standards, but I don't know the extent to which they're actually trying to coordinate those efforts. And, if Accreditation Canada is, somebody's coming from Accreditation Canada, are they timing annual inspections so they're not immediately before or after that? Like, even something that simple would be helpful. Because then you're almost getting a freebie biannual inspection that the taxpayers, well, they sort of maybe indirectly paid for, but that the government themselves didn't do. And so I don't think there's that level of coordination between what Accreditation Canada is doing and the governments. In some ways, the governments are so pushed to act that in this space that you would hope they would work closer with the accreditation people, but I just don't think that's. I don't think that's happening.
Do you have any sense of whether the long-term care facilities are keen to be accredited? Like, are they looking for that sort of additional?
I've heard that sort of more anecdotally. I've heard that the same thing that you've heard in the fertility space where they are, but I'm not sure if that's sort of universal. It's just something I've heard a couple of times.
I think that a lot of these areas they are fairly desirous of that as a way to avoid being regulated.
Yeah, no, absolutely.
So it's an accreditation Canada sells themselves as that. Come be accredited with us and avoid being regulated by the.
Yeah, I think that's an important point as well as the different the different operators. Like, who are we regulating? If you're looking at BC, of course, it's a private, nonprofit, public spectrum.
Yeah.
And, in Saskatchewan, nonprofit government. So there's a disincentive for the government to be regulating itself, essentially, and nonprofits.
Yeah.
So looking at, I think, across provinces and saying, well, in BC, the ulcers or whatever is the same, so maybe the regulation is ineffective. I'm not sure if that's the right kind of approach to be saying without taking into account the fact that they're regulating the private sector to a large degree. Mm-hmm. And without that regulation, we may see an increase in antipsychotic use, falls and whatnot. Now, not necessarily so, because a lot of the, I think, evidence we point to is American-based, not done in Canada, breaking down this data set based on who we're actually regulating. And I think the Accreditation Canada piece is a bit troubling because you're essentially buying to have that stamp, as opposed to a government coming in independently and not being bought for that accreditation.
Yeah, I think you're right that the provincial level data can be massaged, in terms of are there differences in morbidity. I think it can also be massaged in terms of facility level data, because you can look at the facility level, you can group by public and private. So there is a way of doing that. And I certainly had that thought recently in Alberta, the thought of how, what are the quality differences between the for-profit facilities and the not-for-profit. There was a case that just came out in Alberta where the residents were challenging the accommodation fees they were being charged. And the challenge was about the fact that there was a cap on it, and the cap was quite high, and all the facilities were charging the cap, and the allegation was that the cap was way more than the accommodation charges, and that they were sort of cross-subsidizing other people's health care. And one of the things the judge said is, this is interesting because these people are paying these accommodation charges, and the government is sort of providing health care, but since some of these are for-profit facilities, like they're squeezing profit out somewhere in this equation. Well, some of them are profit, some are not. And where is that coming from? The profit that's being squeezed out. And so one does wonder whether or not it's being squeezed out at times in terms of some of these quality indicators. And I've certainly seen studies, mostly from the American context, that attempt to look at quality of care across private versus public facilities. A lot of it's from the hospital context, and there is certainly some evidence of variation in quality depending on facility ownership. I haven't seen a lot of work on that topic in Canada and in long-term care, but I think that in and of itself would be sort of a whole interesting project, is digging really deep into this data set and separating by public, not-for-profit, for-profit.
Yeah. Another way to put it, I guess, is there are some elements of the inter-I data that are low stakes and others that are becoming higher stakes. And I think part of the origin
Everyone might not know what inter-I.
Oh, that's the database that's being used here, the resident assessment instrument. And by low stakes, the thought that comes to mind is somebody in the Ministry of Health says, well, we need to know how many people are getting this care, where the big problem is arthritis versus dementia. That's kind of a low stakes question. The budget of the facility doesn't depend, or their rate of inspection doesn't depend on it. On the other hand, if you start asking about falls, as we've been talking about, that becomes a high stakes kind of question, because it does affect the budget and the amount of scrutiny that the facility will come under. There are all kinds of other contexts, starting with the Ontario Securities Commission for shares and companies, where there are high stakes data reporting requirements and there's independent auditors. And so let me turn it back into a question. If we really want to have regulations that are evidence-based, and the evidence comes from these data, which makes the data high stakes, should there be, or what kinds of external auditing or quality assurance should there be on the data efforts?
I'm gonna respond to the other part, then the question. I have this thought. I've had this thought all the time with this data, that not so much the high stakes, low stakes, but the fact that we've sort of gravitated towards very particular quality indicators that get focused on all the time. The antipsychotics, the falls, the restraints. All the time there's so much focus on those, and I do sometimes wonder at what cost to some of the other quality indicators that are probably not more or less important. So that's a thought that I have all the time. In terms of the actual question, kind of validating this, I would gravitate towards government having to be the one that does that. I mean, I just don't see who else could really fulfill that role. And they're the ones that the budgets and the inspectors are sort of flowing from their decisions. So you would hope that they're able to kind of balance out those different indicators, the high and the low, and to recognize that with the high stakes ones, there are more issues of underreporting, there are more issues, those sorts of things, and to take that into account when relying on the data, that there is that, with the high stakes stuff, that there is that potential for underreporting.
The example you just gave about the fee cap.
Yeah.
Presumably there you wanted to have an independent accounting firm.
Yeah. And I think because it was the subject of litigation, there was much better independent accounting analysis than there otherwise was of that space, because, in that case, everybody was baffled, because these people are charged this sort of, whatever it is, $60 now a day for a private room, $50, however much for a non-private room, and all the facilities are at the cap, even though some obviously cost much more to run than others, and they were saying we're cross-subsidizing other people's healthcare, and even then, even with the level of analysis to bring a legal claim, even then the judge was sort of mystified at who's paying who what. And I think the government probably didn't want to bring their best data because they didn't want to be seen as cross-subsidizing healthcare with accommodation charges, and the other people the plaintiffs didn't have the best data because they were just people who felt they'd overpaid. And so in that case, I think you absolutely do need independent accounting, and there was some in that case, but even the judge was sort of mystified at where money was going, and the government hadn't sort of costed things out in a way that.
Yeah, by the way, on the other things like not so much falls, but antipsychotics or whatever, basically independent folks coming in and doing, in the hospitals, do chart reviews to see whether things are properly collected.
Do you have time for one quick?
One quick question.
There's two hands, so why don't we
sorry.
ask both, and then I'll
Okay.
magically mold them together and answer them.
I'd be impressed to see how you did that. So I imagine that this is part of kind of a continuum of research. You're doing other related. I was just curious what you were planning on doing with this information and the concept of using Kai data to form legislation.
Just keeping it secret among us. No, I'm in the process of writing it up, and I'm trying to take sort of the quality indicators for which there's more reporting, better data, and then there's also though a lot of secondary material written on how we should be addressing these things, and that's what I'm sort of in the process of doing right now. I mean, my hope. I've applied for CHR funding. My hope is to really be able to kind of crack into deep into the data with an empiricist grad student, and to break this data down a bit more. But for the time being, I'm writing it up sort of in the best way possible, sort of given the limits on the data. But the hope is to really dig much deeper with a grad student.
Quick question for Pauline.
Well, one comment, so on the public, not-for-profit, for-profit, so I think I might have mentioned this to you, but Megan McMahon, I'm on her doctoral committee, she's doing work in Ontario. So looking at the introduction of the legislation here, pre and post, and the different ways that not-for-profit, for-profit have responded here in Ontario. So it's good. It's a really good thesis. I've seen most of it. So
I knew you were on her committee, but I didn't know that that's what she was looking at.
That's her work. I would also just suggest that it would be extremely useful, probably for a lot of folks. A lot of folks trying to work with the data, but not a lot of folks who necessarily understand the legislative side. And so I think just even a very simple kind of comparative piece that maps out all of these different regulations and how they differ across provinces might be really, really helpful as a springboard for others to do work with that. So it's pretty simple, not when I say it's simple, it's not that simple, but
Time consuming, but doable.
Straightforward in terms, then there's sort of trying to actually, more granularly kind of bring that to bear with the data. But I think that actually just putting out a typology of what are the differences across all these provinces, and then, then the next part is, why, and what's the impact.